Hello, everyone, and welcome to today's webinar, Does Presumptive Drug Screening Make Sense? Toxicology Practice Findings. I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Waters Corporation. Now, we encourage you to participate today by submitting as many questions as you would like during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have any trouble seeing or hearing this presentation. And this webinar is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab on the bottom of your screen to obtain those credits. I'd now like to welcome our speaker, Dr. Thomas Rosano, a toxicologist and director at the National Toxicology Center and Professor Emeritus at the Albany Medical College. Dr. Rosano, welcome. You may now begin your presentation, sir.
Pleasure to participate in this webinar series and to really have an opportunity to share with you our experience in drug screening practices, both in clinical as well as in forensic toxicology. I'd like to focus this session on the question that is the topic that we have in as the title for this session as does presumptive drug screening make sense? And really talk about the practice-related findings that we and others have regarding the use of presumptive testing in the current environment of drug use and the need for drug detection in that initial process. The experience that I'm going to share with you comes from two centers, as colleagues said. The experience at the Albany Medical Center Hospital and College comes primarily from use of screening techniques for both clinical toxicology, especially emergency medicine toxicology, as well as for medical examiner services that were provided over an approximate 20-year period in the 22-county region surrounding the Albany Medical Center. I also would like to share with you experience that I've had more recently as a toxicologist and director of the National Toxicology Center, which is shown below, which is just across the street from the medical center. And in this environment, we are heavily focused on not only court-related testing, but also clinical testing for addiction medicine and pain management services. So that's the basis of the information that I will provide. So I'd like to start by looking at and thinking about some fundamental principles and methods in our practice of toxicology. Screening and confirmation are an integral part of our analytical toxicology and form the foundation for our findings and identifications. And they follow a principle of sensitive screening, meaning that the methods used for our screening process optimize drug and metabolite identification, so not to miss agents of significance in that initial screening process. And confirmation is focused on really the elimination of false positive screens, and at the same time to use an additional aliquot of a primary specimen to ensure identity and lack of and elimination of any potential clerical or other errors in the processing of those particular samples. That's the principle, and it remains an important principle. Don't miss any drugs, and don't report any drugs that are not true positives. The methods that we use to achieve these principles of analytical toxicology in our practice, both forensic and clinical, the use of either presumptive or definitive methods. And by definition, the presumptive method is a method that identifies the possible presence of a particular drug, metabolite, or other toxin. And it may not be definitive in terms of that particular identification, but it is an identification of a possible drug or drug class. Most characteristically used in this presumptive testing is immunoassay in this day, but certainly we've used other techniques, and including chromatographic techniques that are not of the same resolution or ability for co-identification of diastereoisomers, or otherwise it may not fit into a definitive testing methodology definition. On the other hand, are the definitive methods that are specific identifications of individual drugs or metabolites, and the definition has gotten fairly detailed in terms of being with or without matrix normalization, and it could be qualitative or quantitative. And heavily in the past it was GCMS, but in recent times much more liquid chromatography with MS and tandem MS again most recently. The protocols that are used in the application of these methods are also, the current protocol is a long-standing protocol of screen for drug classes by presumptive methods and confirm only positives by definitive methods. And that has been used for a very long time, and it's based on the premise that our presumptive methods are identifying potential drugs or drug classes, and the confirmation methods confirm that presence and give us a specific identity for the drugs within a particular class. I would propose that there really are alternative protocols that are out there, and provide this alternative protocol, which is selectively screen for drugs and metabolites by a definitive method initially. And confirm, and this is again another variant of it, confirm all positives and negatives. And I'll give you some examples of that. But there are practice changes that are going on, advances in practice that are occurring that are associated with not only the methodologies we use, but also the protocols and their application. The next slide, I'd like to show you what has been going on, at least in our own laboratory for postmortem toxicology for many years, which is really the protocol that I gave as an alternative protocol, which is the screening by definitive LC, MS, MS methods for the last 10 or 12 years, and before that by GCMS methods, and confirmation then by definitive MS methodology as a further confirmation of those findings. What I put up here is a very hard to read slide, but it really tries to gather the drug findings and the frequency of drug findings and for over 10,000 medical examiner cases that have gone through the postmortem lab while I was serving as director of that laboratory over about an 8 or 9 year period. And if you highlight the drugs that are not following the protocol, the new protocol or the protocol I just described in terms of definitive screening, there are very few. They are grayed out, where we were still using for THC immuno testing, lithium, some immunoassays that were used for selective purposes. But in the main, that entire body of work for determining cause and manner of death was following that particular procedure. So I'm very familiar with that procedure. I believe it has great benefit. But it is not the procedure that is used across the practice of toxicology in the various subspecialty areas of toxicology. In postmortem, as I just described, it is heavily used with a definitive screening using LOD threshold, but the screening methods used in other areas, in addiction medicine and pain management, there has been a movement towards initial definitive testing and oftentimes adapting confirmatory methods and using lower limits of quantitation or limits of detection for that identification with reporting of of quantitative results for those that casework. Court-ordered testing, in our experience, in drug courts, probation departments, child custody cases, often has the use of presumptive screening with administrative thresholds, followed by confirmatory testing, again, for positive test results. In employment drug testing, written into the initial and continuing through the federal workplace program in the U.S. is the use of presumptive screening with administrative thresholds well defined for that. In fact, it's those thresholds that really dictate the thresholds that are often used in the commercial production of immunoassay kits and reagents and procedures. There is the availability now, the authorization now for use of definitive screening in that approach, but it really has been heavily presumptive. And finally, emergency medicine and in clinical toxicology are probably the most challenging areas to make a change in practice. And presumptive screening is used in those areas. Quite honestly, toxidromes are used in the emergency departments and otherwise to identify the possibility of stimulants or other agents, and are treated based upon symptomatology and toxidrome classifications. The laboratory helps to some extent, but that's because of turnaround time and the availability of the definitive testing makes it very challenging to provide in this environment. So I'd like to show you something from a number of years ago where, although we were not providing definitive testing for our emergency department on a routine basis, we did evaluate the use of definitive methods and a comparison of those methods with the presumptive methods that were used. This is a pilot evaluation of definitive drug screening in the emergency department setting. It's 200 ED emergency cases. They were consecutive urine samples that were sent for drug testing, and at that time there was a 5-panel immunoassay that was performed, and we de-identified those and were able to evaluate those and analyze those by a UPLC MSMS method that was for 64 drugs and metabolites. And what's shown here, again, hard to show, but in terms of the number of agents, but there were 343 drug findings. Gabapentin was the most frequent drug finding. The second most frequent drug finding was cocaine metabolite, followed by morphine level. And again, across the board, many benzodiazepines, stimulants, and opioid agents are in this particular listing. When we looked at and compared that with the findings that were obtained by Presumptive, we found that 169 of the 343 drugs were missed by immunoassay. And I think this is a very important point. This slide shows the false negative rate for each of the agents. But I think it pointed out something that we don't necessarily have as much data as we have for false positives, but the issue of false negatives and not finding agents that are there. When we looked at this data, we initially thought there was 2 reasons potentially for that. One is the thresholds used as cutoffs in the immunoassay, and secondly is the limited scope of the immunoassays compared to the number of agents that are out there, and the fact that these assays are not looking at the methylphenidates, ketamines, mitragynine, gabapentin, or even fentanyl at that time, which was present in this population at a reasonable frequency. So this set of data and it stimulated us to develop, rather than adapt methods of confirmation, which are really geared towards confirming classes, to develop a multi-drug identification as an initial test for screening. And the results of that work over time is summarized in this slide. It represents a number of advances that need to be made in terms of us adapting definitive methods for routine testing, but it includes automation. It includes use of simple dilute and shoot process. This is for urine drug monitoring. It involves the use of rapid chromatographic separation and analysis with very rapid acquisition and the electronics that are currently available in state-of-the-art mass spectrometry. And it also included a need for matrix normalization. And I'll speak about this more in this session and possibly in future sessions in terms of the significance of this. But we adapted a new technique that, in addition, as an alternative to stable isotope, called threshold accurate calibration. Somewhat like standard addition, single point standard addition, but it is not a single point standard addition. It also included hydrolysis. So before we actually look at what we find when we use this, because this is used very routinely at the National Toxicology Center, hundreds and hundreds of samples are analyzed by this technique. And as I had said before, the practice at NTC has been converted from presumptive screening to definitive screening using this particular approach. I'd like to cover two things before we really get into that data. First is the hydrolysis. Now that we're actually doing this kind of numbers, the number of samples that we're doing and the amount of analysis, we have plenty of data. And in this particular case, I summarized the data with and without glucuronide hydrolysis for almost 1,000 drug and metabolite measurements, and looked at the means and the dispersion around the mean for the actual percentage of the drug that we're identifying with hydrolysis. And you can see that certain drugs exist in the urine sample in the free state almost exclusively, and that a significant number of the analytes, drugs, and metabolites exist as close to 100% glucuronidated. And that the ability to measure glucuronidated is needed, needs a hydrolysis step, and therefore we find it very valuable. It also has an implication for immunoassay. We in an immunoassay, for example, for buprenorphine, where the actual levels and the content of buprenorphine in the urine is almost 100% glucuronidated for buprenorphine and to a large percent for norbuprenorphine. And unless you have cross-reactivity in immunoassay with those, then they will not be a very sensitive measurement. And in fact, you can see that cross-reactivity evaluated for buprenorphine because it's so prominent that it is the glucuronide you're measuring. But for many of the other immunoassays, for benzodiazepines, whereas you can see alpha-hydroxyalprazolam, clonazepam, 7-aminoclonazepam, those ones that we're having trouble detecting sometimes in our screening processes using presumptive are highly glucuronidated, and it will depend upon how that assay interacts. If you look, sometimes it's hard to find what the cross-reactivity is for those glucuronidates. So I'll just comment on that it's an important part of the assay system. The second is, the important aspect is the accuracy associated with matrix normalization. And I won't go into all the details of it, but it is significant. There is a significant variation in the ion areas associated with adding the same amount of a drug to multiple different specimens. And there needs to be this normalization to have an accurate assessment of either threshold or a quantitative assessment. We've been for years using stable isotope for that particular approach in our quantitative confirmatory methods. This is a practical approach to actually doing a matrix normalization using the analyte itself as a reference material, producing a ratio between the analyte that's endogenous in the sample and a consistent amount of analyte that is added to every sample. And you can do this in multi-analyte assays by having essentially 100 different reference materials added and spiked into that particular sample. You can also, once you get a response between the neat, the endogenous, and the spiked, which is a subtraction of the neat from the spiked, you can actually get a response curve that's very much like the ratio to an internal standard that's used in stable isotope dilution studies. And to the right shows the quantitation. So it is a different approach that we've taken, but it has been very effective for us in terms of being able to apply definitive methods for screening. I'll give you one slide that would say, give you a little bit of the publications associated with this, initially reporting the matrix normalization technique in, I think, 2016 or so, and then a quantitative validation of the method. At that time, I think it was 64 drugs. The initial technique was put out with 30 some drugs and as measurements. And then a publication recently on comparing it directly to stable isotope for quantitation, and then a publication addressing how to confirm when you are doing this kind of high volume definitive testing. What do we use for our confirmation methods and meet forensically defensible confirmation? So there's a fair amount of literature that I have out there associated with the use of this technique. But let's go and take a look at how this type of panel of testing over on the left by definitive methods for specific drugs and metabolites compares to a 11 panel immunoassay on the right hand side, which allows us to give that direct comparison. I want to show you first a set of data from 217 addiction medicine cases or urine samples that were obtained from casework, again in a de-identified state. And those particular samples were tested by the definitive methods that I just described before. There were 507 positives in those findings and 1,880 negatives. And I think the negatives and the positives are equally valuable in terms of being accurate with. This is a look at the negative rate and the positive rate for the panel, and it only includes the analytes that are part of that 11 panel immunoassay. It is not the all of the analytes or the antipsychotics and other agents that we measure. It's only for the amphetamines, benzos, buprenorphine, cocaine, etc. It also shows you the prevalence. This is a confirmation population, so it has a fairly high prevalence of drugs in it. And to give you some sense for validation of this, this is an evaluation of that definitive method that I just described to you versus a stable isotope method. And this is for positive, negative identification. And this shows that in this particular group of samples, there were 164 positives by the TAC method of threshold accurate calibration with that spiking with the reference standard materials. And there were 3,417 negatives. There was complete concordance between a stable isotope method that used analyte matched deuterated or other tritiated C14 standards as a technique. So it compares very well, and we have a great deal of confidence in the certainty associated with those particular findings. Let's come back to that group of 217 samples from addiction medicine and take a look now, and over to the left is what I showed you before, was the definitive UDM results showing negative, definitive negatives, definitive positives, and the prevalence. Now I add to it the performance of the immunoassay. And first indicate the true negatives and true positives, again, versus the definitive method itself as the standard for that particular determination of true and false. And also then show you the false negative rate and the false positive rate. And I'd say that it's very difficult to actually have this data sometime where you're actually looking at, for immunoassay, both the false negative and the false positive rates. but there were 60 false negatives and 96 false positives. And if you take a look first at the false negatives, they were high for benzodiazepine, for cocaine, and for opiates. And I'll stay with that, there was also false negatives in some of the other assays at lower frequencies, but still appreciable false negatives. So the actual number of false negatives is shown here. But at very high rates, 15 of the cases were missed for the cocaine assessment in those cases. Benzodiazepine, 24 cases of benzodiazepine. Positive cases by definitive method were negative by the immunoassay method. And again, coming back to why, I'll give you some more a look at that in a little bit in terms of either cutoffs. In this case, since we're really focusing our definitive method on the analytes of interest in those classes of drugs that are measured by immunoassay, this is a high prevalence of negatives due to threshold itself, and I'll show you that data in a bit also. False positives we've known, and we want to avert the reporting of them, and that's why we do confirmations, but this particular assay had a very high incidence of false positives for amphetamines. We were unable in many of the cases to find a sympathomimetic that may be or phenylethylamine that was the cross-reactant, but clearly there were false positives not associated with amphetamine, methamphetamine, or the designer amphetamines that we had on the panel itself. Hydrocodone assay also performed poorly, and I'll show you later why, and methadone also. So let's do something that is probably more. I'll hold just a moment. I have one other point to make about this. So I told you everything about the definitive testing for the panel of assays that are done by immunoassay. Now I'd like to just show you that in addition to those false negatives and false positives, there were also positives by definitive tests that were not tested by immunoassay, including IS, naloxone, gabapentin, pregabalin, ephedrins, dexamethorphan, etc. So we had additional agents, not due to the detection sensitivity, because these assays, immunoassays, were not geared towards identification, but to show you what's in that population of addiction medicine casework. Okay, let's actually look at cases, because that's what really gives us our best education, case-oriented education. And I'm going to give you just as we almost look at it with a case that we have. We receive the medication information in the case. We do the definitive testing, and we're provided with the information on the initial screening that was done by immunoassay. So I'll go in a little different order. In this particular case, this is the cocaine that was missed by immunoassay, a false negative presumptive screen. That's how it's entitled. Treatment with morphine, MS-Contin, a treatment with Zoloft, sertraline, a determination by immunoassay of a positive for opiates, a confirmation performed, and findings from morphine hydromorphone. When done by the definitive screening, we did find morphine at 637 nanograms per ml, hydromorphone at 79. That's consistent with a metabolism of morphine to hydromorphone, and consistent with morphine use, not necessarily dilaudid use. So that gives us some good information. We should have that same information here on the confirmation methodology. But in addition, we found sertraline, norsertraline, consistent with Zoloft therapy. And more importantly, we found benzoylecgonine and cocaine, which were missed by immunoassay. They're well below the 150 threshold, and cocaine was also found in this particular case. The way we reported is inconsistent findings of cocaine and detection, and metabolism. Morphine and its metabolite hydromorphone are consistent with the prescribed medications, as is sertraline and norsertraline medication, consistency with medication. So that comment is put onto the report along with those findings. That's the initial testing. This is we believe, a heroin use case that was missed by immunoassay. It is someone who's on Sublocade, so they're receiving buprenorphine without naloxone. It's called Sublocade as a preparation. Immunoassay was positive for buprenorphine. It was also positive for fentanyl, however, and it was confirmed positive for fentanyl. So there was a fentanyl finding by immunoassay. But take a look at what you see on a definitive side. Buprenorphine is present. Norbuprenorphine, which does not react, this glucuronide does not react in the immunoassay, but it was very high levels, and in fact, norbuprenorphine is usually our prominent finding. Fentanyl was found. It was inconsistent, norfentanyl, and we also found beta-hydroxyfentanyl. We had a recent publication showing that this is a metabolite of fentanyl, so we now have it on the panel. And we also found morphine and 6-acetylmorphine, which were not identified by immunoassay. The opiate assay was negative, but take a look at the concentration, well below the 300 nanogram per ml cutoff for opiates, so I can see why, and also below the 10 nanogram per ml cutoff for 6-acetylmorphine. So this was a case of co-use of fentanyl and in heroin, or heroin together, the current heroin preparations. We see many of these combinations, but it added the fact that this was not just a fentanyl, but a fentanyl heroin sourced case. Next case is kind of an interesting miss. This is a case of use of alprazolam and clonazepam, which was missed by immunoassay. The prescription information was Valium. The findings on immunoassay were benzodiazepine positive. It was actually not brought to confirmation. It was brought later to confirmation. But when it was confirmed, it did find oxazepam, temazepam, and nordiazepam. This is the triad that is always seen in our diazepam cases. We very seldom see diazepam itself, although we have it on the panel. But in addition, there was alprazolam, alpha-hydroxyalprazolam, and 7-aminoclonazepam. These were inconsistent with the medications, and we reported inconsistent findings for them, along with the consistent findings for diazepam. So we missed the fact that this individual is using multiple benzodiazepines in addition to their use of diazepam. Next case is a case of the limited scope of presumptive screening, an Adderall case. It was positive for amphetamine, positive. But in addition, when we did definitive as the initial approach, we found methylphenidate and ritalinic acid. So we know that the individual was on Ritalin, also methylphenidate, and we also found gabapentin, all inconsistent. So we found a significant inconsistent use of drugs by this individual, and in this case, by immunoassay, we just confirmed the use of Adderall itself. This is a false positive. Now on the false positive side, this is a methadone false positive. We've seen a fair number of them, and we see them often when the patient is on Seroquel or quetiapine therapy, because quetiapine or its metabolites cross-react in the methadone assay, which is a reported finding. And by immunoassay, they were treated with Sublocade, which is buprenorphine without naloxone, and also with Seroquel. They found buprenorphine in that case, but they also found methadone, which was an inconsistency. It didn't confirm, and we believe that's due to the quetiapine that we did find when we actually did definitive testing. And just two more quickly, that hydrocodone assay that we see so many positives. Hydrocodone is reacting with oxycodone metabolites, and that's the problem with this assay. Every time we have an oxycodone case, this is somebody on OxyContin, we get a positive oxycodone immunoassay and a positive hydrocodone assay, and it confirms negative for hydrocodone. This is because these metabolites are also reacting in the hydrocodone assay, cross-reacting, and they have very high levels. See, the noroxycodone highest metabolite is beyond our current calibration range. And finally, false positive for oxycodone. And this is a one that I've actually had court cases associated with. This is someone who's on Suboxone therapy. Now, Suboxone is a buprenorphine preparation that has naloxone in it. And when we did the testing, when the testing is done by immunoassay, they got a buprenorphine positive, but they also got an oxycodone positive, and the provider was told that it was an inconsistency potentially with oxycodone. If you look at this, buprenorphine and norbuprenorphine were there, and so was naloxone, and so was noroxymorphone. And this is, to us, a consistent finding that we have, is that when you metabolize either noroxymorphone or naloxone or naltrexone, the dealkylation that occurs results in the same end product. Now, you can call it noroxymorphone, but it's also naloxone or naltrexone. So we see these patterns of seeing naloxone with just this metabolite and none of the other oxycodone metabolites. And again, it's a false positive, and people are sometimes accused of oxycodone use when it's really part of their Suboxone medication. So I apologize for the number of cases, but that's what we live with all of the time, and that's what we think is the benefit of it. I'm going to just provide you with some more, a study that looked at the clinical value of definitive testing before I summarize. And this is a study that has been completed and submitted for publication and is in the review process, heavily into the final stages of the review process for publication. But it's an assessment of the effectiveness of in detection and monitoring of drug use, misuse, and prescription adherence. And I think that's where we're moving to now, not just a positive finding for a drug or a drug class, but an interpretive finding relative to drug use, to drug misuse, and to drugs that should be in the system and are prescribed but are not there. And the study protocol includes 95 drug panel that I showed you earlier that we had developed and done in 5,000 cases. And let's just look at the summary of the findings. This is the frequency of positive drug findings when you use this kind of an expanded panel as the initial test. Where we don't, had we used immunoassay, that would be the gauntlet to say we only look at those agents. This is an expanded look at drugs, and an expanded look at the drugs that are on the streets in our populations today. There was 28,000 positive drug findings in this case. And if you look, and I apologize again, it's very hard to represent this number of drugs and to provide this data in a form, but we put it in terms of frequency, the most frequent being nicotine metabolite, but the next most frequent being buprenorphine, used heavily in addiction treatment and also in pain management, and other opiates, opioids, and other agents that are there. But if you just look at the hatched lines, those are all of the determinations or tests that are performed for drug or metabolite that are not included in the 11 panels that I showed you before. So we're really missing a very significant findings in terms of drugs that are not being monitored for by immunoassay. It also tells you that you need to actually do more interpretation in the laboratory. There was a recent report, Brigham and Women's Hospital, showing that if you just send out these kinds of results to clinicians, you're going to get misinterpretations because they need to know all the aspects of metabolism and the nuances of what we do in the laboratory. And it really begs the question of the laboratory providing interpretive reports which give drug use and also interpret that in relationship to the medications that are present. And that's what we do very routinely. So out of those 24,000 or so tests, there were 18,000 drug use findings. And now that we know drug use findings, we can look for relationship with the current prescribed medication and report drugs that are inconsistent positive findings. Drugs shouldn't have been there. Now, obviously, the illicits are always inconsistent positive things, but even in the therapeutics, the oxycodones, that over 100 oxycodones that were reported in this population, subgroup of all the oxycodones that were inconsistent and reported as inconsistent. We know the medications, so we know the frequency of medications in this population. And I'll just make one side point. There are lots of pain management and addiction treatment agents, but there's also a fair amount of psychiatric drug medications, antidepressants, antipsychotics, and I'll come back to that point in a moment. This is non-adherence. This is another area that we as laboratorians can assist in terms of an understanding and showing that drugs that are not found, no laboratory evidence of use of a drug that is being prescribed. And it's an area that, if you look at it closely, heavily into the the psychiatric agents. Quetiapine is first on the list of this, where we cannot find quetiapine. And we have a sensitive assay with that hydrolysis that I showed you before, and we have very high levels in the use of treatment. So we really have information that may, assist in not only the care of the patient on the addiction side, but the care of the patient in psych service at the same time. And finally, a bit of information that comes out of this, which is important information, is now that we've quantitated and we know out of those 5,000 cases the positives, we can look at how sensitive our detection is as we move from the thresholds used in immunoassay down to the thresholds used in the definitive testing. And when you do that, you can see that the detection rates, this, for example, is use of alprazolam and alpha-hydroxyalprazolam. The red is the parent drug, the metabolite's in blue. It tells you, first of all, that the metabolite is a more sensitive indicator. We are getting positives sooner with the metabolite, higher levels, more in the urine than the parent drug. But both of them show you the increased detection rate associated with lowering the threshold from the thresholds used in immunoassay down to the thresholds used in definitive testing. Same is true of fentanyl, and again, norfentanyl being the more sensitive indicator. The same is true of ritalinic acid and its metabolite, especially the metabolite ritalinic acid in Ritalin therapy. And this pattern was seen across the board, and it allowed us to have real data to say that as we move to lower in thresholds, we are identifying drugs that are missed. And that is one of the reasons for the false negatives that are occurring, and hidden false negatives in immunoassay testing. These are the comparative cutoffs that are used. For amphetamines, we're at 50, and for immunoassay 500. For cocaine, we're at 50 versus 150, and that makes a difference. Almost half the cases are between these particular levels, and morphine, we're at 50 versus 300, and that's the lower limit for that particular evaluation in that study. And you can now go and actually predict the false negative rate in immunoassay based upon this population, where we know the concentration of the agent, and we can say, would we have found it by immunoassay? And this mirrors very closely, for example, for cocaine, a 33% prediction of a false negative. And we have clear evidence in the smaller cohort study done earlier that affirms this high level of false negative for cases. So I'd like to kind of summarize and really come back to the question of whether presumptive methods are meeting our needs in toxicology, and start with some of the findings. The drug class immunoassays are not selective and require additional confirmation testing to identify specific drug use. Well known. False positive rates of up to 100% occur in immunoassay, and that example was phencyclidine. We have some phencyclidine positive cases, but in the main, when immunoassay finds phencyclidine, it is a false positive case. But we do have high rates of false positives in other assays, as I showed you earlier. False negative rates, up to 45%, also occur in immunoassay. And immunoassay, therefore, does not meet the basic principle of drug screening in toxicology. We need sensitive methods that are detecting the agents that are in the population so that we can inform those and then go on to any specific measurements that are needed after. And this is where I think we're falling short now in terms of the false negative rate for this. The false negatives caused by high cutoffs and by limited scope of testing. The study also shows, and the experience over time also shows, that definitive screening application is demonstrable and usable in routine practice, and shows improved screening sensitivity, selectivity, and clinical effectiveness. So in conclusion, I would say practice-based evidence shows that presumptive drug screening does not make sense, and that we really need to look towards advances in practice that will allow us to use our more sensitive and specific measurements in the initial testing process. And that is quite a challenge, because I think the first response is, how would we ever, convert to definitive testing across all of our practices? And I think it is going to take innovation in terms of automation, techniques for matrix normalization, and data management. And I hope at some future session to be able to give you some more information on some of those challenges and speak more specifically about data associated with them. But at this point, I would like to say it's, again, a pleasure participating in this, and I look forward to answering any questions that you may have, and also learning from those who are out there in practice, because it really is a collaborative process, and for us to continue to advance the practice of toxicology. So thank you.
And thank you, Dr. Rosano, for that informative presentation. We will now start the live Q&A portion of the webinar. And if you have any questions you want to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. So it looks like, Dr. Rosano, we already have some great questions coming in from our audience members. Our first question is, how time element presumptive immunoassay using drug test kits is the fastest available screening method. What is the time element involved in UPLC MSMS for a single urine sample?
So we do most of our testing in a batch format, and samples are processed. Sample prep takes place in the morning, analysis by late morning, and the actual testing in terms of the chromatographic testing takes into the evening and into the night. So it is the next day, next morning results review, and for the initial testing. If that's in a forensic environment, then there would be the findings from that, and it would be on the next run of the next day, that particular next day, that would be put on for confirmation. So for the initial screening, it is next day. For confirmation, it is a 2-day process for that.
Thank you so much. Dr. Rosano, costing of alternative versus current protocol. Could you talk a little bit more about that?
I'm sorry, the cost of it is the question?
The question, costing of alternative versus current protocol. What could you talk a little bit about maybe costing of alternatives?
The cost is really, there are two aspects of the cost that we have seen. One is the investment that needs to be made in capital investment in equipment and personnel for the definitive testing, which is higher than the capital investment for immunoassay screening or presumptive testing. On the other hand, we also looked at the variable cost in terms of the ongoing cost, which in immunoassay is the individual reagents for each analysis. And in mass spec, there is lesser amounts of that variable cost. So it really is a volume issue. And it also is an industry issue in terms of the cost of capital and otherwise. But as you get to higher volumes, and we find it about between 12 and 15,000 cases per year, that if you take a look at the analysis between the two, that they are very similar in cost, in that with high volume, the cost of immunoassay actually is higher because of the ongoing reagent cost for each of those tests. So at the lower volumes, immunoassay really is a more cost-effective, but at higher volumes and above, it really it inverts in terms of the cost.
Thank you so much, and I want to thank our audience for these great questions coming in. Our next question from an audience member: how did you select the drug panel for your definitive panel?
That's a question that we addressed very early on in terms of how do we transition to definitive screening from presumptive. And we initially developed panels that actually were the individual drugs that are in the classes of drugs performed by immunoassays. So we had a what would be called a very basic panel that would be inclusive of all of the testing that was currently done in the classes of drugs by immunoassay, and did have that available. But very rapidly we moved towards the expansion of that because, as you see in the data, there are drugs in use that are not being identified and tested for by immunoassay. So we went to a panel that was initially a drug abuse panel that became approximately a 64 drug use, and it included opiates, opioids, benzodiazepines, stimulants, and other agents, and we continue to evolve, and designer drugs that come on, we are looking at closely for addition to it. So we have that panel, but we, at a particular development point, we also started looking at the therapeutics. And this whole issue of the antipsychotics and antidepressants were added. So now we're at about 195 to 100 drugs in a full panel. And our approach to it is that we acquire the data on all drugs, the fundamental ion data on all drugs, but only analyze that data for actual drug findings for the drugs that were ordered in the case. So we're able to be very flexible in terms of doing basic panels, or the drug of abuse panels, or the drug of abuse plus the therapeutics in a single chromatographic process. And it is going to take efficiencies to make the use of this very effective definitive procedure applicable in various settings. And we have I hope to have a session coming up to actually address some of these details, but that's in summary what we've done to identify panels.
Thank you so much, Dr. Rosano. We have time for one more question. How does the initial definitive testing affect turnaround time for results?
Well, as I'd spoken of earlier, the initial testing itself is started on day one and is completed on the day after, and results are available in a clinical setting. Now that we've gone direct to definitive, there is the opportunity to report definitive results if initial testing is in a report. As I said, in the forensic, we will never get away from the need to have a second test. Even though we have enough certainty associated with the identification in the initial test, we will still need the second test. So those samples that are positive and in forensic casework, they are then evaluated by the certifying scientist and put on the run of the next day for the following, for that particular preparation, and then a reanalysis from a primary specimen. So it is approximate 2-day process of testing for full forensic casework, and again, we're doing the initial testing in a definitive mode, so negatives are done by definitive. Since we are using large panels for the confirmation testing, which we have reported the use of TOF, for example, in confirmation testing, we are able to actually reanalyze even the positives and the negatives in those particular cases for confirmation of positives and negatives in terms of our findings.
Dr. Rosano, thank you for your presentation today, sir, and for your important research. Would you like to provide any final comments for our audience before we go?
Yes, I think that this is a challenge, and all of us, this has been a significant number of years of development in our own laboratory. I think that it's a challenge for the industry themselves to actually provide us with the kind of automation that is needed, provide us with the informatics support. We didn't have a chance to really talk about it, but the amount of data that one generates in these systems requires an informatics solution that allows the analyst and the certifiers to actually look at the important data and not have to do a lot of calculation of information. So we have many things that are challenging to us in our laboratories, in the industry, but fundamentally, in terms of what's going on in terms of drug use and misuse and compliance issues, we really have a need to address this and to meet this challenge.
Thank you, sir, again for your presentation. And I would like to also thank LabRoots and our sponsor, Waters Corporation, for underwriting today's educational webcast. And thank you again, Dr. Rosano. Before we go, I also want to thank our audience for joining us today and for their interesting questions we didn't have time for today, and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. And this webcast will be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Stay safe. Bye-bye.
It's a pleasure. Take care.